Good day. The topic for today is oral cancer. Okay, oral cancer or cancer, also known as neoplasm, as defined by R.A. Willis, is an abnormal mass of tissue, the growth of which exceeds and is uncoordinated with that of the normal tissues and persists in the same excessive manner even after the cessation of the stimuli which evoke the change. So, once this definition has been given, we've been following this definition, and this neoplasm has been divided into two, that is benign and malignant neoplasms. Benign, wherein the growth can be large, but then it does not invade the adjacent tissues and does not spread too quickly. Whereas the opposite of which is the malignant neoplasm, is also known as the tumor. So tumor as such is an abnormal mass or collection of a tissue. When there is damage to DNA that occurs, usually a normal cell undergoes repair. When that does not occur, the cell undergoes mutation, and in the presence of oncogenes, whereas genes that induce cancer, these cells undergo a progression and then form a tumor. So the tumors that pertain to the oral cavity are the ones affecting the hard palate, soft palate, tongue and the lip. Sorry, not the soft palate, hard palate, tongue and the lip. The ones that affect the soft palate, the pharyngeal wall, the palatine and the lingual tonsil come under the group of oropharyngeal tumors. Why this differentiation is important is because when the staging is done, to what extent the spread can occur to, there will be a difference in oral cavity cancers and oropharyngeal cancers, which we will get to. The majority of the oral cancers are squamous cell tumors, and the others include salivary gland tumors, lymph node tumors, bone and soft tissue neoplasms. So the average age for diagnosis of these tumors is about 60 years, because immune suppression is one of the causes for tumors to occur. So in the later stages of life, it is going to be, because the immune surveillance for elderly is less, there is going to be cancer occurrence more so in the elderly. The most common sites are the lateral borders or the base of the tongue, because the lymphatics that is connected to the tongue and that of the base of the tongue, the spread of the tumor from these sites is going to be at large more when compared to the other sites. It's the sixth most common malignancy in Asia. So the sites and the factors that cause or are a risk to cancer are smoking, because of the nitrosamines, the hydrogen cyanide and the nicotine that is produced from smoking. People who smoke are at a risk of cancer for primary and secondary cancers. Meaning primary meaning due to smoking they can have lung cancer, or if it is a secondary cancer that is not related to smoking, the risk it goes down to 5 to 10 years after quitting. So although the risk is there, once you quit it, it reduces. The alcohol use is another risk factor. Beer and wine have increased risk than any hard liquor. So they have a synergistic effect. When you combine smoking and alcohol, it has a synergistic effect because of the dehydrating effects of the alcohol on the mucosa. The permeability of the nitrosamines is greater when you smoke after alcohol use. So the mouthwash that is used by smokers also can predispose to cancer, which is why not more than 15 days an alcohol containing mouthwash is prescribed to any patient. So HPV, a virus can be a viral oncogene can also induce cancer, specifically HPV type 16 and 17. So malignant transformation is by the expression of the oncogenes E6 and E7. Weakened immunity, like said earlier, is one of the other causes for predisposing oral cancer. So because immunity is less and the immune cells cannot attack the cancer cell that is formed, it can predispose to cancer. So there are inherited cancer syndromes of no fault of ours with any habit. There can be people with Fanconi's anemia, Cowden syndrome, xeroderma pigmentosum, or dyskeratosis congenita who can develop oral cancer or any type of cancer. Nutritional factors are if there are antioxidant vitamins that can protect us from cancer. If those vitamins are less, that is intake, no proper diet has been maintained by the patient, that is in deficiency of vitamin A, D and K, they can be a predisposing factor to cancer. Prolonged sun exposure, usually not in our country, but for Caucasians, because they're very fair and they lack a little melanin pigmentation, sun exposure and melanoma causing Caucasians is common in the Americans. So the other factors for lip cancer include pipe and alcohol use, but still prolonged sun exposure can cause oral cancer, specifically affecting the lower lip. Chronic irritation is another factor caused by dentures or sharp teeth or cheek biting. The trauma can transform the epithelial cells, and the proliferation of which can lead to cancer if not treated. The other factors include betel quid chewing, gutka, pan masala usage, and anything involving the oral cavity, that is specifically the buccal mucosa, can be affected. The hyperkeratosis and epithelial dysplasia can be caused due to the use of betel quid, gutka and pan masala. Other oral conditions that can have the potential to cause or predispose to cancer are lichen planus, leukoplakia, erythroplakia, actinic cheilitis and submucous fibrosis. All of these, because they can cause cancer, they are potentially malignant diseases. So the pathogenesis, how does one normal cell become a cancer cell by mutation, is usually when there is DNA damage, our body has the ability to repair the DNA damage. So if that does not occur because of radiation or some viruses or chemical carcinogens, as in your smokeless or smoke tobacco, nitrosamines, viruses like HPV, or if there is going to be a radiation, because of this the DNA damage does not repair successfully. So there is going to be genes that affect the apoptosis. Apoptosis is programmed cell death. Once our body knows that the cell is not normal, usually cell death occurs. But if there is going to be a gene that affects the apoptosis also, this mutated cell continues to grow in the presence of oncogenes and the inactivation of the anti-oncogenes. Our body also has the ability to kill off these cells, but if that does not occur also, the cancer cell grows by tumor progression and clonal expansion. So cell to cell adhesion is lost, causing tumor progression. The spread of the cancer or the metastasis is usually of three types, which is lymphatic spread. All the carcinomas occur in the body through lymphatic spread, and hematogenous spread are sarcomas. They spread along the the last one is spreading along the body cavity. What to look for when you are suspecting oral cancer? There are certain signs that tell you that there's going to be cancer or dysplasia present there in the oral cavity. What can you catch when you look for cancer is if there is a chronic ulcer present over 14 days. The patient tells you it's not healing, then you have to suspect. If there's a swelling with no edema, no pain or redness, because they cancel out all chemical mediators of inflammation. So specifically pain is inhibited when there is a tumor. Also, if there's going to be a tumor that is very large, all the free nerve endings or the nerves have been destructed in that area, there's not going to be any pain. So if there's a swelling with no pain, if there's persistent bad breath, loosening of teeth for no known cause, if the patient is having loose teeth all throughout his oral cavity, then periodontitis can be suspected. But if it's for a specific region where there is no specific cause, where there is not much of calculus or periodontitis that can result, but there is loosening of teeth, then you can suspect. Infiltration into other adjacent tissues. If there's paresthesia, if the patient tells you that one area is numb, feels like it's swollen but it's normal on clinically appearing. If it is a salivary gland tumor, there can be obstruction of the salivary ducts. If the patient feels that the saliva is not very free flowing, or if the patient has dryness, if there are enlarged hard lymph nodes and if the lymph nodes are fixed on palpation, if there's sweating, malaise, anemia, loss of appetite, and with the weight loss is with no apparent cause, there's difficulty in swallowing if it is an oral pharyngeal cancer, if there's ear pain on the lateral border of the tongue. So this is one of the specific causes which we forget to rule out. There can be ear pain for a patient who has a tumor or who has a swelling on the lateral border of the tongue. It can appear as a very small swelling, a small tumor on clinical examination. Well, on palpation, maybe there can be hard fixed nodes, and one feature that the patient can complain of is ear pain. So that can also be looked out for. Elevating dentures suddenly, because there can be an expansion of the jaw or the arch, any bleeding that is profuse, or a red and white lesion or a potentially malignant lesion that can be looked out for. So how does it present itself is, it's a red, white or mixed red and white lesion. The change in the surface, as in if it's not smooth, there can be a granular rough surface. An ulceration or a mass can be present. It's an elevated or flat lesion. It can be minimally palpable or can be indurated. Indurated meaning it's a feeling of firmness that can be palpated. High risk sites for carcinoma are the lower lip, anterior floor of the mouth, and lateral borders of the tongue. So the varicose carcinoma is a grainy papillary verruciform fungating or cauliflower-like lesion. It's a type of oral squamous cell carcinoma that can be seen. On the picture here, you can see that there is a varicose lesion. That is a cauliflower-like lesion on the lateral border of the tongue, which is red and white. It's an ulcer due to chronic trauma. Oral potentially malignant diseases. The term potentially malignant was defined by the WHO as the risk of malignancy being present in a lesion or a condition either during the time of initial diagnosis or at a future date. So there can be a risk for potentially malignant diseases to become malignant. The most common ones are what we see in our clinics are leukoplakia, erythroplakia, oral lichen planus, and oral submucous fibrosis. So it's a predominantly white plaque-like lesion, leukoplakia, with a questionable risk, having excluded known diseases or disorders that carry no increased risk for cancer. It most commonly affects males and smokers or with smokeless form of tobacco. So HPV associated also is seen, that is proliferative verrucous leukoplakia, which is commonly seen in females, which is an exception for leukoplakia because most commonly seen in males. It's asymptomatic, non-scrapable. It does not disappear on stretching. Why this feature is important is there is another leukedema, which is a developmental or disorder or can occur as a precursor to leukoplakia in the site due to smoking also, which disappears on stretching. The types are homogeneous and non-homogeneous. Speckled and non-homogeneous, there are two varieties, speckled and nodular forms. The classic appearances are cracked mud appearance, which is leathery and a dry sand-like appearance. Ebbing tide appearance, usually seen on the floor of the mouth or on the ventral surface of the tongue. And the buccal mucosa is the most common site usually for a leukoplakia to occur in a smoker, the commissure of lip, and in proliferative verrucous leukoplakia is the gingiva. White uniform color is one of the features for homogeneous, and if it's a mixed lesion, it's a non-homogeneous type. So if the leukoplakia is over 2 cm or 200 mm, it has an increased risk of malignant transformation. So PVL here, there are multiple patches of leukoplakia present and has a risk of malignant transformation. It's an increased risk for malignant transformation. So this is how they appear. The first image here shows homogeneous leukoplakia, typical cracked mud appearance, a dry appearance at sea. The second and the third images on the top show that there is nodular, that is speckled. The first one is speckled and the next one is the nodular forms, non-homogeneous forms of leukoplakia. The ones below The first image is an example of the ebbing tide appearance seen on the floor of the mouth for leukoplakia. The last one here is proliferative verrucous leukoplakia, which is common for in females in the gingiva to occur. So erythroplakia, it's a fiery red patch that cannot be characterized clinically or pathologically as any other definable disease. It is irregularly outlined and well circumscribed, but there is a velvety surface that you can see. Most common appearances in the palate or the soft palate. Smoking and chewing tobacco are the causes for the same. Oral lichen planus, it's an autoimmune disease affecting the T cells on the basal epithelial cells and most commonly occurring in females. Usually there is bilateral presentation for oral lichen planus and burning sensation is one of the causes, but mostly burning sensation presents only when there is a red component involved, that is when there is one type, that is the erosive or the maybe the ulcerative type of lichen planus where burning will present. The types are reticular papular plaque like erythematous, bullous, ulcerative or the erosive type. 6 P's of skin lichen planus. It is a dermatological disorder also affecting the oral mucosa. So the 6 P's include the pruritic, planar, purple, polygonal, plaque and papular. So these are the things that you remember. One characteristic feature for any type of oral lichen planus is you see something called Wickham's striae, which is a lace-like appearance that is seen. This can be explained here. The first one here, the first image on the top left is the annular or the reticular type. The second one on the top is the papular type, also with the reticular type that is seen. Yes, the third one also, that is lichen planus, that is the plaque type of lichen planus. And the ones below, the erythematous form that is seen, along with these squamated gingivitis, that also is a common feature with that of any lichen planus that present. The second one in the second set that is below is the ulcerative or erosive form of lichen planus, and the last image is the Wickham's striae, which is commonly seen in most types of lichen planus. Okay, the oral submucous fibrosis, it's a disease caused by areca nut chewing. Many people make this mistake that there can be a habit where the patient chews areca nut, also smokes, but it's not caused by smoking. It's caused only by betel nut chewing or areca nut chewing. There is loss of fibroelasticity of the lamina propria and restriction of mouth opening because it's a disease that inhibits the collagenous activity affecting the collagen in the oral cavity. So there is increased production of collagen, because of which there is a shiny appearance, there's a marble stone like appearance of the oral mucosa as such, and there is burning too when the patient takes spicy food. And this epithelial atrophy and fibrosis along the salivary ducts, so reduced salivary secretion also occurs in the later stages of the disease. Initially, because of burning, any ulcer we get in the oral cavity, due to burning there will be increased salivation just to act like a coating over the ulcer. So initially there is going to be increased salivation, but later stages of life, because of the ducts being blocked due to fibrosis, there is going to be reduced salivary secretion. Vertical palpable bands are going to be felt along the buccal mucosa and the circumoral areas. The circumoral areas, if the bands develop, there's going to be a feature called as the buttonhole mouth, which is like a purse strings, similar to that of which is seen in scleroderma, which is again a connective tissue disorder. The uvula is going to be shrunken, is going to be upturned like a hockey stick, or a bud-shaped uvula is going to be seen. Restricted tongue movement, cheek flexibility is going to be reduced and can present with other oral potentially malignant diseases or frank carcinoma. Other diseases meaning, if again, like I said, if the patient is going to be an areca nut chewer, also a smoker, leukoplakia can also present with a patient with oral submucous fibrosis. So in the picture 1 that we see is the buccal mucosa. Like I said, there is going to be limited mouth opening, and the marble stone appearance, meaning the pinkness of the buccal mucosa and that of the oral mucosa itself is lost and becomes very grayish white. The third picture on the top, you can see that the uvula is upturned like a hockey stick. So lower one, you can see the second picture that the tongue movement is restricted. Cheek flexibility is also reduced in the last picture. In the last picture, there is also a growth on the buccal mucosa that you see. So it can present with the oral cancer also. So how we diagnose it is, usually the gold standard is histopathology. And for the diagnosis, a full thickness of the epithelium shows dysplasia. Dysplasia meaning there is going to be a change in the cell size, the morphology, mitotic figures are going to be increased, hyperchromatism, there's the color is going to change, nuclear size alteration, it's going to be large, nuclear cytoplasmic ratio is going to be altered, and the normal cellular orientation and maturation is going to be altered as well. So these abnormalities along the length of the entire epithelium, also involving the basement membrane and furthermore invading into the connective tissue, can be seen. So grading and staging. The difference is grading is to be given when there is a histopathological relation, and staging for clinical differences in the types of oral cancer. So the American Joint Committee on Cancer has classified it with regard to T, N and M staging system, where T is the tumor size, N is the presence of lymph nodes or the involvement of lymph nodes, M is the metastasis. So there are 4 stages, 1 to 4 for oral cancer. So they are different for different types of cancer. Even for oropharyngeal cancers, it is going to be slightly different. So TX or NX or MX, M0 meaning there is primary tumor cannot be assessed, there is no lymph node that's involved, and there is no metastasis. But from TIS to T4B, you can see the differences in size, that is it ranges from 2 to 4 centimeter, and how the extent of the tumor is when it is involving the adjacent tissues for T. And for N, we will get to that in the next slide as to how it is involving the contralateral or the ipsilateral nodes with sizes ranging from 3 to 6 centimeter and multiple nodes, or if it is a single large node. For M, it is going to be either the metastasis is present, distant metastasis is present, or it's not. The stage grouping is from stage 0 to stage 4C, depending on the T, N, N, and M present. So yes, this is for the lymph nodes. If N1 is any lymph node that is in the affected area which is less than 3 centimeter. If it is 3 to 6, it is N2A. And if it is less than 6 centimeter, but there are multiple nodes involved, it's 2B. Multiple nodes on both sides is 2C. And if it is over 6 centimeter, it is N3 on the same side or on the opposite side. The diagnostic aids in oral cancer are, usually the gold standard is going to be tissue biopsy, but to primarily dig in and then take a biopsy at certain sites is going to be very difficult. So before that, if an optical diagnostic tool which is non-invasive is present, it is going to be much easier. Or if the optical tool present is going to tell us that this site is preferable for a biopsy, then it is going to aid us in diagnosing the oral cancer better. So we have vital tissue staining techniques, computer assisted cytology, oral brush biopsies, optical diagnostics, and saliva, which can be a sampling tool. Toluidine blue or toluidine blue vital staining technique. It is done for potentially malignant lesions also, to see if there is going to be any dysplasia present, to check whether this site can be biopsied for or not. So there can be retention of the dye, which can tell you that it's a false positive also. So this can happen in inflammatory or ulcerative lesions. So you do the test again in 14 days if you think it's going to be a false positive. It's a dye which has an affinity to bind with the DNA of the cell. So in a cancer cell, there is going to be, or in a cancer area, there are going to be more number of cells. So more number of cells, more number of DNA present. So there is going to be a blue stain that is taken up in that area. So the procedure here is, so as you see in the picture, the first one, there is an erythroplakia on the lateral border of the tongue on the left side. So once we do the procedure, initially you rinse it with water for 20 seconds, acetic acid, 1% acetic acid for 20 seconds, and toluidine blue next. Again you rinse it with acetic acid, which is another fixative, and then rinse it with water. So then you will see that the area there has taken up the dye, and you select this area for a biopsy. Visual adjunctive tools, that is busy light and veil scope, are two visual adjunctive tools which tell you when there is going to be it's a light based technique which tells you areas that can be biopsied. You rinse with acetic acid again for the same thing. Oral cavity is examined under chemiluminescent illumination at 430, 540 and 580 nanometer. It allows visual distinctions between normal mucosa and oral white lesions. The hyperkeratinized or dysplastic lesions, when viewed under chemiluminescent illumination, they appear white, and normal epithelium will absorb the light and it appears dark. So this is how it's going to appear. The areas that have increased dysplastic cells are going to appear white, and the normal mucosa is going to appear dark on the chemiluminescent illumination. So autofluorescence spectroscopy is using fluorescent light instead of chemiluminescent light, and the suspected area, that is any area with a potentially malignant disease, is going to show loss of autofluorescence, which appears dark. So this is because the area is going to contain more amount of FAD or NAD, because there are more number of cells there. So there's going to be increased glucose synthesis, and then increased glucose is going to be present because there are more number of cells which require more amount of glucose. So this is useful in discovering mucosal abnormalities and oral potentially malignant diseases. It does not usually detect early disease. So if the disease is going to be in the later stages, then this is useful in identifying the disease. So this is how it will appear. So you can see there is going to be a white patch that is seen at the ventral surface of the tongue on the left image. On the right, as you can see, this white patch, the area there on the right shows loss of autofluorescence because it is irradiated under fluorescent light. The toluidine blue staining is cleared by the Food and Drug Administration as an adjunctive marking aid in combination with chemiluminescence light device, which can be not just a standalone diagnostic tool, it can be in combination to aid in the biopsy of the disease. So in addition to these diagnostic aids, there are also histopathological examination can be done with an FNAB, with a ultrasound guided FNAB, which is minimally invasive, whereas staining as well as optical diagnostics are non-invasive. So the treatment, so the principal treatment is to cure the patient. And the choice of treatment depends on the cell type and the degree of differentiation. If it is going to be a poorly differentiated tumor, which is a large tumor, then it cannot be resected. So you'll have to shrink it, or then when you have to see where it is. If it is involving any vital organs, then you should think of the quality of life of the patient also. If we are going to remove a huge chunk of tissue from the face for a patient, if it is going to be oral cancer, you have to think about the quality of life too. So it will depend on the cell type, degree of differentiation, site and size of the lesion, lymph node status, whether if the tumor is going to be small but the lymph nodes, the sentinel node is there in the, maybe if the tumor is in the tongue and the sentinel node is in the level 2, then if it's just one node, it can be resected. If it is going to be spreading to other nodes below in the neck also, a radical neck dissection can be advised for a patient. But still, again, the quality of life has to come into play when treating patients with cancer. There is presence or absence of bone involvement, ability to achieve adequate surgical margins, presence or absence of metastasis, ability to preserve oropharyngeal function including speech, swallowing and aesthetics, and complications of therapy. Usually, if the patient is treated with cancer, if the treatment is still considered successful if the patient lives, but the quality of life after that is, if it is going to be affected too much, then there is no use of curing the patient of cancer. The types of treatment are surgery, radiotherapy, chemotherapy, and targeted therapy. So if it is going to be T1 and T2, a small tumor that is present, surgery is preferred. So radiotherapy, it is a principal treatment if it is going to be in the initial stages, or if it is going to be slightly larger, you can shrink the tumor and then perform surgery. So chemotherapy is performed in the advanced stages of the disease as induction therapy. So initially you give them chemotherapy, see if the tumor size has been reduced due to chemotherapy, then you can perform a surgery to remove it. Targeted therapy is you direct, or immune therapy is where you direct all the growth cells or the WBCs in our body, or the immune cells in our body, to attack the tumor cells. So there has been technical advances in radiotherapy too, that is intensity modulated radiotherapy or image guided radiotherapy and proton beam therapy. This is because they reduce the size of the high dose irradiated field and limit the exposure only to the vital structures, that is the area where the radiation exposure is needed. For example, if it is going to be an oral cavity tumor, and there is going to be unnecessary exposure to the salivary glands, and because of which there can be complications. So to avoid that, intensity modulated radiotherapy or image guided radiotherapy with the use of PET scans, they have devised a plan to irradiate just the area where the tumor is present and make it free of irradiating all the other vital organs surrounding it. So surgery, the indications, if it is a localized tumor which is small, and if the tumor is involving bones, the side effects of surgery are less significant than those associated with radiation. You perform surgery first. And tumors that lack sensitivity to radiation, so like in there are certain areas which are highly sensitive to radiation, areas wherein there is increased rate of mitotic activity. So certain areas are less sensitive to radiation. So when there is less sensitivity to radiation, and when you give them radiation it's not going to work, then you perform surgery there. In surgery, adequate margins, if it is necessary, then you perform surgery to remove the tumor. If the margins are not clear, then surgery is a bad option, and it may recur too. So when surgery is performed on large lesion, there is a loss of a huge chunk of tissue, again affecting the quality of life. So in radiotherapy, it's usually used alone or in combination with chemotherapy for palliative care for patients who have been deemed not to radiate them and to cure them with radiotherapy. Palliative care can be given to such patients. So radiotherapy in very short radiations can be given to such patients just to ease them to take in food alone, or the improvement in quality of life. When used in palliative care, they provide just symptomatic relief from pain, bleeding, ulceration, and oropharyngeal obstruction. So direct action is through DNA damage and cell death, and indirect action is because our body is made up of water for 70%. DNA damage through first there is radiolysis, that is the photons affect the water, and then the biological molecules, free radical release, DNA damage, and cell death. So it is effective in destroying cancer cells, radiation, but it is done in fraction because in normal cells there's increased rate of repair than the cancer cells. So these cancer cells, because of their increased growth rate, they become more radiosensitive. And why it is fractionated is because the cells, as in if you see in the picture here, the tumor cells at the center are hypoxic, that is without any oxygen. So the more the number of oxygen in the cells, more oxygenated the cells are, more they become radio sensitive, and they can be reduced in size. So for any radiation to reach the center of the cell which is hypoxic, they have to be reduced in size, and once they reach the center of the tumor, the cells at the center have been reduced and the cells at the center have become oxygenated. So you can reach the center and then reduce the size of the tumor. The administration of radiation can be of different types, like explained earlier. There can be IMRT and IGRT, where it's image guided and only the certain areas that require irradiation have been irradiated. Any area that is vital and does not need to be in the line of fire has been removed of receiving radiation. So there are other techniques which are implant techniques or brachytherapy. If the tumor is to be very localized, for example in the esophagus, if the tumor is very localized in the mucosal lining and only radiation to that portion is required, external radiation is going to not spare the other regions and is going to involve the other vital organs which are to be in the line of fire, that is the radiation. So for that, brachytherapy, which is an implant technique, is given. So when the implant is placed there, only the region surrounding it will be irradiated. External beam radiation, where small boost fields are given, they prevent damage to the adjacent tissues. And a proton beam, which is tailored to the ideal target, and there is a rapid drop of radiation when not required. It can be combined with chemotherapy or surgery. For an advanced disease, usually it's combined with chemotherapy. So radiation with surgery, where radiation removes the oxygenated cells, shrinks the tumor, and then surgery can be done later. In some cases, all three may be required. You split, and then only the oncologist will decide as to which treatment comes first, radiation, chemo, or surgery, and then devise a plan for each case. So what the complications can be for radiotherapy are, there can be acute complications as in mucositis, because the oral mucosa is a highly radiosensitive area. If it's going to be oral cancer, more so than often the oral mucosa is going to be irradiated, so mucositis can result. The infections, that is fungal and bacterial infection, can result due to irradiation because the WBCs, there is going to be a hematopoietic syndrome wherein there is going to be less number of WBCs, that is granulocytes. So immune system is also weakened, so the infections will set in. Salivary gland dysfunction can occur, like sialadenitis and xerostomia. Taste dysfunction can also occur. Taste dysfunction is reversible 120 days after irradiation too. But chronic complications are fibrosis and atrophy, radiation induced fibrosis, salivary gland dysfunction, because there is less saliva to wash the area, there is going to be dental caries that present, osteoradionecrosis, taste dysfunction, dyschezia and ageusia, muscular fibrosis or trismus, and muscles, it's going to be in the later stage because muscles is a very less radiosensitive organ. The infections can be fungal or bacterial infections even in chronic cases of patients with radiotherapy. So all of these can be managed in the initial stages, but if the patient is having an oral cavity cancer that is quite large and the case is hopeless, there are going to be chronic complications too, but the symptomatic management only can be done for such cases.